Are there any questions you've been dying to ask in the course of the afternoon or you brought with you today? Eva. Yeah.
Just something that you said, Dr. Vicky. You spoke about how you use CBT as the method of psych with the Something I've read lately is that CBT doesn't really work with head injuries, and myself, with my experience, I had CBT treatment for a very, 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 very long time. It didn't do squat. So is there a different modality that you could be using?
So I think
It should be on. They should all be
so.
on.
I think CBT is a very broad term, and the best CBT is targeted to the person and to their particular problem, and it's all about helping them to problem solve their problems. So I personally don't think it is particularly helpful in more severe brain injury, but with the young people that we see who often come with their own anxiety issues, what it's doing is helping them to manage those into the future, helping them to make sense of what is an irrational fear, like I'm never going to be able to get drafted to the AFL because I've had a concussion. So it's working on those irrational things. It's a very specific approach. We don't recommend kids who have a concussion goes to any psychologist and does CBT in the community. As John had said, you really needed to target both in the psychology area and in the physio area to very specific things. So, that makes sense?
I'm a CBT therapist, and when I see somebody, especially the first time I meet them, I'm like, if this doesn't feel right to you, if I'm not your cup of tea, please move on. Like, not every therapist is the same, and a lot of people do a weekend training and put up that they have something. I do know that Mount Sinai is now doing a research project where they are actually looking at evidence-based treatment and doing a whole approach with brain injury specific CT, that word. So I think there's a lot of hope in it, but also if a therapist isn't working for you, go find another one. And I'm one of the few therapists in our area that has brain injury as a specialty, so I see a lot of people that are really desperate. If your therapist doesn't know about brain injury, move on.
Next. Yeah.
Hi, my name's Louise Vanu. I'm a neuropsychologist. I just wondering if the panel had any thoughts about the crossover between persistent concussive symptoms and functional neurological disorder. I've read a few papers where there's some ideas that they could be one of the same. I was wondering about your thoughts.
John?
This is a very controversial topic. I've never found a journal article that's told me what percentage of people that present with persisting post-concussion symptoms are FND, functional neurological disorder. But we know that there are a lot, and the issue is that you need to have a clinical psychologist who is very well versed in both the treatment of functional neurological disorder and persistent symptoms. The longer the symptoms go, the more the sort of psychological elements sort of come in. At Epworth, we have a functional neurological disorder clinic at one of our campuses and have a concussion clinic at the other. And there's certainly some interplay between the two clinics, and some people get referred, but it's a very small number. But I think some people feel that persistent symptoms, post-concussion, is a subset of functional neurological disorder, and other people find the other way around. And I don't think we have the evidence to fully answer that question, but it's a good question, and sometimes we've been denied the ability to see patients, the funding, because there's been a judgment, oh, this person's got a functional neurological disorder. So I think you've always got to keep it in the back of your mind that there's a treatment overlap, which doesn't help, but if we have a psychologist that's worked in both clinics, so I feel confident that as much as possible we can determine the difference. But it's still a topic that needs a lot more research.
And if I could just add to that, I think the earlier you get in with people that might be susceptible to FND, the less likely it is to happen. So now that we're doing interventions on a regular basis, we seem to be seeing far less instances. Although I should say, during COVID, we saw a lot more FND than we're doing now. So you know, some of it's about what's happening in the community too.
I had a question along similar lines. You were describing concussion as being the symptoms plus an appropriate mechanism of action, but how do you actually decide what's a sufficient mechanism of injury to give a concussion? I've seen people that have bumped their head on the way getting into the car, or you know, stood up and hit a cupboard, which hard to decide how, you know, how much of an injury that may have led to.
Michael, do you want to have a go? Yeah.
It's a good question. There's no specific cut-off or anything there, and we often see it even if we're watching a game of whatever sport you're watching, that you know, two people collide, one's on the ground unconscious, the other one gets up, dusts themselves off and runs off. It's the same force. They've hit with the same force. So it's not just about force, it's the whole picture together. So there's a bit of subjectivity to it at the moment. But it is, when I say plausible mechanism, you've got to have some form of head trauma and the symptoms coming in a reasonable time frame afterwards is enough to say, I suspect that this is a concussion. So it's not about saying, you know, this force plus, you know, these symptoms is a concussion. It's just about that recognition. Mechanism, clinical symptoms or signs, I've got to be thinking concussion. So that's the point of saying it like that.
Is there anyone you rule, or any mechanism you rule out just through the force, even if the time was there and the symptoms were there?
I think the statement, when in doubt, sit them out. And when I was training parents and coaches, I said, if you think you need to go to the car to get, like, you know, whatever concussion, what's the one with the eye thing that everyone does?
Eye tracking.
If you think you need to go get your King Divic kit to assess somebody on the sideline, you've got doubt, right? So that's the, and you know, if they continue to play another 20 minutes, you're doubling that recovery time. So if it's 14 days, now it's 28. If it's 20 days, it's now 40. So that the risk, you know, hey, you miss it, you're gonna have a mad kid, you're gonna have a mad teenager, you're gonna have an annoyed person. But the risk of pushing through is doubling a possible recovery time, you know? And anytime I ever pulled a kid, and I coached boys lacrosse for 6 years, I never pulled a kid that later on, you know, that parent sued me, or they said, you ruined my life because I missed that game. So I think that when in doubt, if you're thinking there's a problem, that's kind of your answer.
Jason?
Yeah, no, I was just going to say, I forgot what I was going to say. No. I think in that situation, I guess sometimes there is that secondary gain by getting that concussion diagnosis, and that's probably more the point, I think, because the process, whether someone's had a head knock that you think is possible or not, the process of working through, whether they go graduated return through player, whichever, is exactly the same, whether they're concussed or not concussed. So for me, it's sometimes, and I get your point in terms of, in a game, you know, you've got the parent on the sideline or the coach saying, hey, 5 minutes to go, blah, 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 is he concussed or not? I think it becomes irrelevant to diagnose a concussion.
Can I exercise my prerogative and ask a question which is related to what you've been talking about for the past 10 minutes, which is the potential psychological overlay in symptoms, or the underpinning? Because part of the reason why we're having this conversation today, part of the reason for this seminar, are the kind of people who contact me, many of whom are many, many months down, sometimes years after a concussion, and there's always the question that arises about whether there is some manner of, again, psychological mental illness history, pre-injury history. What interests me is how in clinical practice, for a lot of people who contact Brain Injury Australia, their life instantaneously changed on the day they had their concussion. The same with severe TBI, obviously, as well, but the concussion changed their life. I am nothing like the person I was before I had this injury. How do you go about then, as it were, interrogating a pre-injury history that may explore questions about mental health without the person feeling like they're being gaslit?
So I think the first thing you do is get the media not to sensationalise things, because that's what people hear, and so when they get a concussion, they're terrified. So it's like PTSD, right on the spot. So to me, that's absolutely the critical thing. But taking a little bit deeper than that, different concussion, and it's exactly the same as you know, Nick, in more serious traumatic brain injury. There's no way you can, there's no formula that you can use on things like severity or force or any of those things that will tell you who's going to do well and who's not. And to me, it's all around resilience, and I'm not. That's not a judging kind of label. Some people are more biologically, mentally, psychologically more resilient to traumas, whether they be physical or mental health, than others. And what we see clinically is that the less resilience you have, the more likely you are to have those symptoms.
I guess my reflex response to that is that resilience isn't ordinarily a quality that gets shared around equally, if you know what I mean. So for those people who may have, been from that kind of demographic that's at greater risk of TBI regardless of severity, that resilience may not be as readily available to them. So when they're asked about their pre-injury mental health, they may take it in a way that might be confrontational, adversarial in some respects. Yeah.
That's an interesting thing, because I would have said in my clinical practice 2 or 3 years ago, if I said to the parents and the child, you need to see a psychologist because you've got these problems, they would have thought I was crazy. But I think people are really getting their heads around this idea that it's not such a bad thing, that actually a psychologist might be able to help these problems. So if you phrase it that you're not suggesting a psychologist because you're crazy, you're suggesting a psychologist because you've had something happen in your life that's derailed you. I think it's the way you tell that story.
Yep. And that was what I was driving at in the question in some sense.
I also think with that when you're in the clinic and you're assessing a patient or someone who comes in to see you, it is part of the process that you go through. So I think there were a number of symptom checklists where it's divided into somatic, emotional, sleep, and right from the outset, I would say to the patient, we're going to explore these domains, and it just becomes part of the normal conversation. How is this impacting on you? How are you coping with it? Becomes part of the, okay, tell me about your sleep now.
Right.
And so I haven't really had anyone come back and say, what, are you telling me I'm crazy here?
Yeah.
And exactly what Vicky's saying, there really is an openness now to saying, look, this is one of the areas that's commonly affected after a concussion or head trauma. We need to manage this part of it as part of the overall management of your problem. So, and I think a lot of people in this space who are working in the area are using similar language with their patients.
Where was
I think there's also a change to mental health. I see kids from age 6 and up, and on Zoom, and I'm so surprised when kids will say, they'll be on Zoom with them, and then they'll get a phone call like, I'm talking to my therapist right now. I need another 20 minutes. Like, these kids are pretty open about being in therapy. So I think that is incredibly helpful. And just on sleep alone, you could talk to somebody like, what was your sleep like before the concussion? What is your sleep like now? What sleep pattern do you think would be great? You know, like, how late do you play video games? I feel like these topics, and that's where I think clinics where I'm a fan of social work, being a social worker. In the United States, we're seen as discharge planners or therapists, but we're not in that medical model. It would be a neuropsychologist with a much higher billing rate because financially we don't rate. But I think that mental health being a part of it, because of exactly what Vicki said, is it's a life transition for everybody, including the parent that may be driving the kid back and forth, or suddenly the kid's home every day when they used to go to a sport. So I do think that there's a new mental health awareness, so that maybe 5 more years from now, there'll be even less stigma.
Yeah, up the back there.
Hi, thanks everyone for such a great afternoon. My question's for Catherine. So in the domestic violence domain, say we have women presenting in court, etc. How do you propose that we support these women, or is there any screening that's happening in the US? How do we get screening for these, to support these people who are experiencing this?
I just came from a 2-day conference in New Zealand, and I spoke at 8:15 yesterday morning, which I was much sharper. It's interesting, by 4 and a flight up this morning, I'm a little less sharp, but there was a lot of talk about, and an incredible amount of fear, that if women, and we've seen this already in Canada and the United States, if women gets a diagnosis of a TBI, will that be seen by the court as a reason to take away the children, and then the children will be with, in this particular instance, we're talking about the other parent, the father, who may be the perpetrator. And so that is an issue, is do we want this as a screening where the information is included already in the court documents, or is it something done on the side and then based on the case? And also, are we in front of a judge and in front of a court system that understands that just because a woman has a brain injury doesn't mean she can't parent her children? So there's a lot of thought as we push more into this of women's fear, and especially of women of color, Indigenous women, and this was very heavily a group of Maori women, and talking about the fear of systemic racism and colonialism of having your children taken away. So if you go into a court system and your TBI is being discussed as evidence of the violence, will that also be turned on you and your children will be taken away? So there's definitely, like, how do we support women? How do we make sure the whole court system is educated? How do we make sure police are educated all through the systems? And there's some great people out there doing the training. And that's why I really like this task force we have, because people in brain injury go into the domestic violence space and they don't always know. We saw that shift during COVID, where sports researchers are like, oh, domestic violence, we'll do that now. And they don't have the language. So it's cultural humility and trying to find this blend. We're not there yet, if that answered your question.
Yes, another question at the back there, yes.
Yeah, just back on the mental health conversation. I was wondering if in the rehabilitation programs you ever find a role for psychiatrist input, where mental health seems to really be impacting recovery, and by extension, how do you continue to manage those patients who you begin to suspect their symptoms are more mental health related than concussion in an ongoing fashion?
John?
We have a sports psychiatrist associated with our clinic, and we can refer and do. And in one of our campuses, mental health and rehab sit side by side. So we've actually got quite a good resource of access to psychiatrists. I suppose our number one person is the clinical psychologist, as I've said before. But yes, we do have psychiatrists available in the clinic who have specialty in particularly sports concussion.
Can I just add to that? I know it's a very interesting topic you talk about, because there's one of the professional sporting teams in this country who employed for a period of time a psychiatrist to their team, and then by the end of the year there was somewhere, I think it was maybe 9 or 10 of them became medicated as a result. Read into that what you will, but that was a really interesting topic actually. He doesn't work there anymore.
Mark, yeah.
Yeah, thanks Nick, thanks everyone. Sports GP from Adelaide, maybe Michael or anyone really, but And it's usually women and girls who have this problem, but they'll come in with a hockey, they're playing state hockey, state netball, maybe doing athletics, and someone's got a concussion from one of those or even from school, and all the guidelines and protocols, I've just been looking them up, so lacrosse SA's got 6 days, Hockey Australia's still got 2 weeks, and I can just imagine these conversations and say, look, Doc, 6 days is the quickest one, we can graduate to return to play and return to learn, and how about we whiz through the 6-day one and then we'll tick off all these other sports. So what's your guidelines when you've got multiple, children or adults with multiple sports and you're doing a return to sport strategy, and how do you, make everyone happy, including the lawyers, and how are we going to be judged by the AIS guidelines or by the state sport guidelines if something goes wrong?
Yeah, it's an excellent question. It's a real challenge with the multiple guidelines that exist, and what we try to do, and certainly what the AIS has tried to do, is to have a approach that could be used by all sports, and that's the intention of the AIS guidelines. And we spent a lot of time considering the AIS guidelines with what we had, and came into line with the AIS guidelines after lots of discussion and consideration for that reason, to try and have some uniformity in the approach, because people don't just play AFL or netball or one sport, they often play multiple sports, and it's about trying to have a consistent, simple message across the board. I think the AIS guidelines have gone a long way to do that, but we still have a little bit of work to do. But I can't comment any further than that. I know individuals who will still shop around for whatever guideline that they prefer, or whatever doctor might return them a little bit quicker. We're not going to be able to solve the problems of healthcare and that side of things, but I think we're all mindful of that issue and all trying to have a fairly harmonised approach, particularly to recognition, but also return to play.
Yes.
Hi, I'm an acute physiotherapist working in a public hospital in Melbourne, and find, I guess, a gap in care for the patients that are non-compensable, non-insured. And I guess I'm after some advice of what we can do for these patients. That we might have some public options, but they've got typically long wait lists and not necessarily specialist care. So that's one area. And then I guess probably we need to improve the care in the public follow-up space, but trying to advocate to a hospital that's already under pressure, concussion isn't necessarily the highest on their priority list.
There's a referral right there, is there? Huh?
Oh, I'd just like to throw in an advert that we now have a publicly open clinic at the Alfred with a very short waiting list.
Problem solved.
And we're happy to take statewide referrals. So please send your patients through to us at the Alfred.
Okay, enough of that.
Perfect,
okay.
Thank you.
Who was next? Go ahead, please.
Oh. I'm a physio in a public hospital as well. I work in the emergency department. Often I don't actually touch base with people with concussion. Sorry, are you pointing at me?
No.
Pointing at someone else?
It's just the semaphores that happen between chair and conference producer sort of thing. Go on, please.
I was having a discussion before. Often my role would be to do a vestibular assessment on people when we're querying BPPV as a cause of dizziness. But I guess just as an aside, if we're getting people who are coming in with concussion, at my hospital we get a lot of people who are affected by domestic violence and might have had like physical violence. And obviously, the management there is not, like, the priority is probably not on managing a concussion. It's more about making sure that these people have access to a safe place to go and supports, and that they're mentally okay. I guess what my question boils down to is, like, we've got these amazing guidelines that are coming out from the AIS and in the sporting area, because we've got funding there to do this research. In people that are affected by concussion from other means, like through falls or domestic violence and things like that, what would the priority be? Because I know it's a really multifaceted approach as well. It's sleep, it's mental health, it's exercise, it's like graded return to activity. Is there one thing, if I had a patient come in and say, I can't do all of that, I can't manage all of that, that's too much for me, is there one thing that you would prioritise over anything else?
Please, don't fight, please.
I think one thing at a time is a really good thing, and it might be of interest that there's actually some quite good research, physio-based research, that's available that shows the advantage of having physios in the ED, and often it's around being the person that gives the psychoeducation and sometimes even diagnoses the concussion. So I know in our ED, often our team diagnoses the concussion before the ED registrar does. So just being there and on the lookout for that's really helpful. But I think if you keep in mind that graded approach and just getting, if you can tell the patient you've got in front of you that it's about that first 48 hours first and let them get through that and then get to the next stage, that's really the critical way to go about it.
And specifically with the domestic violence, I have resources from Rachel Ramirez, the Ohio Domestic Violence Network. They're free, downloadable, very easy to read, very, very attractive. It's not just like a printout from something, where they're handouts that you can give in a situation where you're meeting someone with domestic violence. They don't have time to go in for a scan. They're trying to get their kids and their pets to safety. They're trying to running for their lives. But there are some really nice resources out there that say, hey, you could think about this. Here are some things that you could do. And just the fact, kind of float the idea, because they've been told, they've been gaslighted that they're bad, stupid, crazy. So again, it's just opening up and starting the invitation, and I have some resources if anyone would like those.
I've heard twice this afternoon that the media sensationalise this issue. What do you think, what sort of damage do you think the media does? And secondly, what do all you think, how should the media be portraying it?
I might start if that's okay. I think what we're seeing, if we survey, and I'm looking at it from an AFL lens for the moment, if we survey past players or talk to past players, they are all petrified that they're going to get CTE. Every one of them. And when you take them through, and so every time they forget their keys, wherever they've left them, they think that's the first sign, and they're about, not far away from either committing suicide or not remembering anything. And it is unbelievably stressful for them. And when you assess them, can talk to them and reassure them, you see this weight lifted off their shoulder, and we've got past player programs now where we're able to at least get some players through that program. So I think that there are quite significant harms there of anyone who's ever played a contact sport thinking that they are going to be in strife. The second bit of that is, again, mood disorder is common, particularly at the elite level in retired players. Mood disorder is common in the community. And the link between mood disorder and a neuropathological diagnosis also makes people despair, think that there's no treatable cause for their memory disturbance or brain function disturbance. And that may increase the risk of mental health disorders even further, and potentially suicide. What I'd like to see is balanced reporting, and we really don't have that. Any time where we get an opportunity to speak or educate, we're seen as big pharma talking about the wonders of sport and ignoring all the risk, and that's never the case. What we're trying to do is make sure that we're speaking in a balanced fashion. There is a risk, there are benefits, we need to work through this.
Hello, Simon. I'm a GP. Keeping in mind that maybe 2/3 of traumatic brain injuries aren't reported, just like Jacob experienced, he felt good for a couple of days. My 16-year-old high-level basketballer at 12 months fits all the criteria of post-concussive syndrome. Absolute classic. The only problem is that myself and his whole treating team had never even asked him if he had a traumatic brain injury. So we've been treating him for chronic fatigue syndrome for the last 12 months. And today I learned maybe he actually had a traumatic brain injury. Chronic fatigue syndrome, functional neurological disorder are a couple of diagnoses that I think we should now ask, was there trauma at the start of this? Any others?
Who wants to have a crack at that one?
Long COVID might be the other one you put in there too. And I go back to the issue of resilience. So in our rehab clinic at the Children's, we see chronic fatigue, we see chronic pain, we see chronic concussions symptoms, and we see long COVID. And it's amazing how similar the symptoms are. And in saying that, I'm absolutely not minimising those symptoms in any way, but I think we don't know what the factor is that's underlying that, and whether, how we need to understand the mechanism, which may be that resilience I was talking about before, so that we can actually work on it. So I think that most of those, in the experience that we have, there's an underlying trauma. It doesn't have to be a physical trauma. It doesn't have to be anything as a parent you're even aware of, but it's something that's triggered a trauma for that individual person.
And perhaps, the social supports aren't necessarily spoken of enough, and they can either prevent people from going forward or the opposite. So I'm sure Vicky's seen this, a lot of parents, you're not going back to playing that sport, and that's very destructive. So I think I agree with Vicky. There's nothing more that you can say, but it's a major sort of issue.
Can I ask you, Jacob, what was the response of your teammates, school peers, friendship group about your concussion? What was their attitude towards you as the recovery seemed to extend and continue?
So yeah, like most people with my situation, everyone was kind of surprised at first when they first heard that I had concussion.
Yeah.
But I was really fortunate. I had a really good support network around me. The senior boys in the team, they made a hamper full of lollies, chips, and all other. Yeah. Yeah, it actually did. Yeah. So they made a nice hamper there, and my schoolmates were just constantly checking in on me. Obviously, yeah, you lose a lot of social connections when you're just sitting in your room and just trying to rest. But yeah, no.
So there was nothing, no machismo, no toughen up princess, none of that kind of stuff happening? No?
Nah, not so much from my friends. Obviously, it's varying for different people, but yeah, no, they were all really supportive, and my family as well as GP. So yeah.
Yes, yeah.
It's interesting because that still happens in professional sport.
Yeah.
You get that machismo, even though it's frowned upon. And in fact, a game just last week, we had one of our players who received a head knock, didn't report to the trainers because he was starting on the bench, and he wanted to show the fact that he was still tough enough to otherwise get through. Didn't make it through the game, came off, and self-reported at the end, and then was crying in the rooms afterwards because he didn't, and now he realised that he was probably worse off for it.
Wow, okay. Yes,
can I just add to that?
Sure, yeah.
We've been doing education sessions for all of our AFL and AFLW teams now for a few years, and at the end of the education session there's opportunity for question and answer, and this is one of the first years that I've seen many of the leadership groups get up at the end of the presentation and say, as a team, we're taking a stand here, we're taking this seriously. It's not weak to report symptoms, for your younger guys who are looking for your place in the team. So I think we're seeing a real cultural shift in what's happening, and that acceptance that you've got to look after your brain, and reporting symptoms is that first important step.
Yeah. Right. Couple more questions?
Just wondering on your recommendations or advice on dietary advice for acute and post-concussive patients. I've just read some bits and pieces on dietary advice, and it can make a big difference. Just wondering what the thoughts are.
You're the resident dietitian, John?
Sorry. Look, this is a very early sort of topic. I mean, my dietary advice is for severe and moderate head injuries to eat chocolate, but that's clearly wrong. Where we first came across this is that some people with anxiety, depression, or just being taken out of their normal lifestyle have significant problems that are really eating disorders. They've either put on a lot of weight or lost a lot of weight. However, there's a lot of research being done into vitamin supplements, and I haven't been persuaded yet to put my patients on one thing or another, but we've got an upcoming conference where I'm hoping that one speaker will sort of review the literature on that, because it's an expanding topic, and we've actually only put on a dietitian over the last 6 months. So I think there is an answer to that question, but there's not much research done at the moment. But I'm certain there will be some good advice about possible dietary supplements. A lot of it's not really supported by evidence at the moment, which is why we tend not to go that way.
Hi.
I promised that I would get you out of here at 5 o'clock for your Saturday night festivities. So one last question, I'm being instructed. Is that right? Yes.
Yep. I'm just
one
here.
final question.
Better make it good then, huh?
That will make available a yes or no answer. Is that the idea? Yes. Okay.
Brooke Doherty, paediatrician, teenage sport taxi driver. Mine was around, and it's probably for Vicky and Michael. We hear time and time again sort of return to learn before return to sport, and I think it was really important that Jacob just mentioned how socially isolating being removed from his team was, and particularly obviously we're seeing lots of elite sport athletes coming to see us. I just try to understand a bit more about why it's sort of that is trotted out again and again, and whether you feel like it's a flexible recommendation.
Great question. When we say return to learn, I think we're really talking about return to school, which starts with return to social connections. And I talked about Mia. One of the things that I didn't say about Mia, she had a very different experience to Jacob. She was really ostracised because she had ongoing symptoms, and she got a special deal. She had longer for exams. She could, sit her exams in separate places. She didn't have to do homework. And so her peers, they were girls rather than boys, so that may be why they were so mean. But they gave her a really hard time, and that impacted her recovery. So our approach, and it's not just in mild head injury, it's obviously a more severe injury, as I'm sure is yours, is that the social connectedness is really important. So we get kids back to school as soon as they can, even if it's just for lunchtime or morning break. And then it's the cognitive load that we leave till last, because I completely agree that social connections is really the most important thing for recovery.